Yeah, no, everything's fine. I'm just trying to figure out if I can attach this.
Hello again, everyone. I'm just going to give a brief introduction to one of our topical speakers while she gets ready. So this morning we have Dr. Kartika Pilar giving us this talk this morning. She's an assistant professor in the Division of HIV, Infectious Disease, and Global Medicine at the University of California in San Francisco. Her interdisciplinary research focuses on the social determinants of health in HIV, diabetes, and other chronic diseases. She is also the principal investigator of the 5-year Women, HIV and AIDS, Diabetes, WAND study, investigating the role of social and economic factors, including food and housing insecurity, on diabetes health among U.S. women with HIV. So join me in giving her a round of applause as she gives the talk this morning.
Great, thanks, Tristan. So you can hear me with this? Okay, great. Welcome. I'm so happy to be here and to have been invited into this symposium on a very important topic, and particularly that the role of food insecurity and gentrification is being recognized. So I'll be talking about that and particularly focusing on housing insecurity today. So there's 3 things that I would like to have us learn by the end of this talk or have a chance to reflect about. First, really, what is food insecurity? I'm not assuming people are coming into this room having thought a lot about this, specifically the way that we talk about it, and what may gentrification have to do with it. I'm going to talk about how food insecurity undermines health in a variety of ways. And then I'd like you to come away with understanding a little bit about this approach to addressing the role of food in healthcare, specifically that people are calling food as medicine, which is just one among the many ways that food may improve health. So starting with Food Security 101. I'd like to take a moment actually to just step back before talking about food security and think about the last meal that you had. Maybe not here in the symposium, we were all kind of together, but maybe the last meal where you really lingered over it or not, maybe yesterday. Think about what you ate, but also think about where you got that food. How much did it cost? Who were you with? And what was the context that brought you to that moment with that meal? Because when we're talking about food, we are talking about a physiological reality of human beings. There's a chemical, there's a biological need that we have. But food is also emotional. It's mental. Food can be love. Food can be pain. It can cause stress. It can cause shame. It can cause joy. Food also affects our relationships. We eat with people. Food is community, is culture, is identity. Food is certainly affected by behavior, what we eat, what we choose to eat, but also by what we can afford, where we live. In the world, locally and globally, is affected by systems. And there are disparities in these conditions that affect food and affect health. So when we talk about food insecurity, we're talking about the limited access to adequate food for a healthy life. We're also talking about uncertain access. So not just limited today, but do you know where your next meal is coming from? And we're also talking about the ability to procure food in a way that's personally and socially acceptable to you as a person and to you as a household. So without having to resort to, for example, stealing, or for some people having to go to a food bank. So this is an inverted pyramid that describes kind of the categories that we think about for food security, really with the most severe levels at the bottom that represent constrained diet intake and disrupted eating patterns. And really, when people talk about hunger, that's really where they're talking about often. But food insecurity is more than just frank hunger. It's also constrained access to quality food, to food that's healthful for the human diet. It's also worry up here in marginal food security, worry about where food is coming from, anxiety about food supplies. So we know that food insecurity affects about 41 million individuals in the United States using just those bottom two triangles. If you add in the worry and anxiety, that number would increase. And that's about 15 million households. Okay, so I like to just think a little bit about the relationship between food insecurity and income, because I think that this is a question that often comes up. So just for audience participation, think about all of the food insecure households in the US. Where do you think they fall in relation to the poverty line, roughly? And poverty line federally is about $25,000 for a family of four. How many of you would say A, maybe at about half of the poverty line? How about B? How about 1.5 times? 2 times? 2.5? I think we have a pretty equal distribution. Some tails at the end. So it's actually 2 times the poverty line. I think 97-98% of households who are food insecure are at or under about 200% of the federal poverty level. Now I'm going to flip things a little bit, so try to kind of flip those numbers in your head. If you think about everyone who's under the poverty line, so that's under that line of $25,000, what percentage of those people do you think are food insecure? 30%? Raise your hand. How about 40%? 50%? 75%? 90%? And you know it can't be 100% because of the previous slide, so it's a trick question if I had put that on. So this may surprise some people. It's actually 40%, actually 38%. And this is really important. So income and food insecurity are closely intertwined, as we saw from the first kind of question, but they're not synonymous. Less than half, at least by the USDA definitions, of people under the poverty line actually are food insecure. And that's because food insecurity is shaped and affected by things other than simply your income. It's your access to resources, other safety net resources in your environment. It's social support. It's what else you are doing to kind of cope with the income that you have to achieve a level of food security. Yes?
I just have a quick question.
Sure.
When you quote household, that's household in regards to low poverty, but then you have homeless, correct?
Right, yeah. That's a really great question. So these are the numbers that are given by the USDA, and I am actually not sure how they include that in their numbers. So I will look and get back to you if you're interested. After the talk, please come and So there are also disparities in food insecurity that fall along all of the same lines as our speaker who just talked about gentrification mentioned. So Latino and Black households in particular are at disproportionate risk of food insecurity, and that is pretty entrenched over time. These are older data. I mean, these stop at 2008, but nothing that I've seen indicates that this has changed, and in fact, maybe getting worse. Okay, so food insecurity in the context of gentrification. There are potentially many ways that food insecurity would interact with gentrification. I'm going to talk mostly about the top one and a little bit about the bottom one because of my area of expertise and what I can speak to. The first one, housing insecurity. Thinking about the cost of housing, displacement, and what happens in the context of changing affordability of housing in a neighborhood. The second is changes to the neighborhood food environment. The kinds of retail food outlets that are available, grocery stores, the types, the numbers, the cost. This bottom one I'm not going to speak too much to, but I just want to mention that There's a lot of really fascinating research about neighborhood food environment being done by many amazing people that I absolutely encourage looking into. And there's a lot of debate as to what the effects are of, for example, locating a grocery store in a neighborhood that hasn't had one. What is actually the effect of distance of living from a grocery store? And I think that the evidence is showing that it may matter, but also what matters is the prices. Is it a grocery store that people want to go to? Does it reflect who they see themselves culturally? Are they comfortable going into that store? But I'm going to talk now about housing insecurity. And so the first aspect is really this trade-off between the cost of housing and food budgets. And so there's a lot of research showing this fundamental trade-off that people are making, and because rent is a fixed part of the budget for most people, the place where things can wiggle is often in food. And so that's going to be either reducing food intake or changing the quality of the food, or getting food that is less healthful. Oops, I wanted to go back to this. Excuse me. Oops. We do know that people who rent are at much greater risk of food insecurity than homeowners, even for a given level of income. And there's been some really interesting recent work showing that on a county level, nationally, those counties that have the higher cost of living is specifically determined by rent prices. The residents in those counties have significantly poorer sort of nutritional and diet quality, and lower scores on the healthy eating index. And that the way of measuring cost of living using rent was more predictive of that than actually food prices for looking at diet. So I thought that was very interesting. The second aspect of housing insecurity is really about displacement and the inability to afford housing, maybe not being able to stay in your housing and having to go to poorer quality housing, or losing your home altogether and becoming homeless. Eviction. Being from San Francisco, this is a huge issue for us right now. And that affects, of course, food budgets and thinking about affording food. But I wanted to point out another really important point around food utilization, because food insecurity isn't just about being able to buy food, but being able to actually prepare the food, store the food safely, and be able to utilize it in whatever place that you're living. So if you don't have access to those, to a place to store the food, a place to cook the food, it limits your options in terms of the food that you can consume. So in 2014, we did a qualitative study with people living with HIV who were food insecure in San Francisco to try to understand their experiences. And I just wanted to share some of their voices with you, because even though this was sort of a broad study about food insecurity and HIV, topics about gentrification and housing insecurity came up as a very salient theme throughout the interviews. So the Tenderloin, which is a neighborhood downtown, some of you may be familiar with it. One participant said, "The Tenderloin is changing a lot. The rich are trying to get in here and live here. They want to kick all the sick and poor out, and they're being successful at it too." There was a lot of despair about this and this changing neighborhood, which really was a place of refuge for people when all the other places in the city were becoming completely unaffordable. A second participant said, "You've got to pay rent or be in the streets. You've got no choice to make." And the SSI, which is supplemental security income, a form of disability income, don't go up. I mean, you may get $1 or $2 or maybe $5 every 2 years, but rent goes up, once a year, so what can you do? Almost everyone in our study was on SSI because they were living with HIV and often long-term survivors. And this in turn led to a trade-off between rent and food. Most people who were housed were able to do so because they had housing subsidies from the city or from other sources. And so one of our participants said, recently I just got the $200 rent subsidy within the last 6 months. I only get $925 a month, and before then I was paying the whole $900 for rent. And I was getting food from the food bank and Project Open Hand, which is a local food service organization, and just where I could, because I couldn't afford it. But I had to have a place to stay. So that was the trade-off that this participant made. So now we're going to talk about the link with health. And I want to start by showing you this framework, and I apologize that the writing is probably a little hard to read, so I'll just walk through it briefly. This really shows how food insecurity and chronic illness, particularly diet-sensitive chronic illness, exist in a cycle. My colleagues at UCSF developed this. And it shows that food insecurity really constrains dietary options and leads to different strategies to manage during times of plenty and during times of shortage. And that these strategies can, during shortage, skipping meals, balancing out the kinds of foods you're eating, even during plenty, maladaptive coping strategies, maladaptive for health at least, I think adaptive for life, but maladaptive for health in terms of maybe eating foods that are very high in calories but low nutritional value may continue, and continue to raise the risk for things like diabetes, hypertension. Once people have these things, food insecurity then makes it difficult to manage because you have to follow a diabetes diet or a hypertension diet. Stress comes into the mix and continues to affect weight gain, inflammation, disease progression. People become disabled, have a difficult time working, which leads to food insecurity, and it can continue. So we do know this is a 30,000-foot view of the literature on food insecurity and health, but it's just amazing the range of health conditions that food insecurity has been linked to, either the risk of or the prevalence of. Diabetes and HIV, STIs, kidney disease, hypertension, heart disease, osteoporosis. I think there's even been more studies since I made this slide that I just saw, I think, yesterday and couldn't add around arthritis. So it's really predictive of poor health across a range of conditions. But the place where there's been the most research so far has been around diabetes and HIV. And there we see that in addition to just being linked to having the condition or acquiring the condition, we see that it really affects the health when people are living with that condition. It affects adherence to medications and healthcare, ability to kind of follow self-management regimens. It has a profound impact on mental health. Clinical outcomes, so for HIV, thinking about viral load, CD4 count, for diabetes, glucose, A1C, there's evidence on all of these things being undermined by food insecurity. And then finally, increased healthcare utilization. People have increased visits to the emergency room, increased hospitalizations. So this framework is really thinking about what are some of those pathways that might lead from food insecurity to health. And there's really these three pathways, nutritional, mental health, and behavioral, that are kind of reflected from the literature that I saw. So this was also developed by my colleague Sherry Weiser. And I'm going to walk through just each of these pathways, because I'd like to give more of a flavor for some of the data behind them, as well as some more of the qualitative research that we've done to bring out the voices of how things feel under the numbers. So for the nutritional pathway, we do know that food insecurity is associated with a range of poor nutritional outcomes, poor diet quality, nutritional status, both underweight during times of shortage, and overweight and obesity. Difficulty meeting health-specific dietary recommendations, as we were just discussing. And so one of our participants who has diabetes shared this quote with us. Either you go hungry because you don't have the money for fruits and vegetables, or you're eating empty carbohydrates. You know, say pasta, spaghetti, mac and cheese, you name it, that will last you for 3 or 4 days. So here you're eating this stuff that isn't good for you. It turns to sugar, but you're kind of stuck between a rock and a hard spot. Our participants expressed this a lot, feeling like they couldn't win no matter what they did. Thinking about the mental health pathway. As I said, there's a lot of literature linking food insecurity with a range of poor mental health conditions, including just overall mental health, but particularly depression and depressive symptoms. And among people with HIV, which is where our work has really centered, we found among women living with HIV, there's really this very clear gradient of increasing depressive symptoms as food insecurity becomes more severe. Among homeless and marginally housed people with HIV in San Francisco as well, we saw a similar gradient. That sample was mostly men, but also had some women. A quote about this: "When you don't eat properly, then all of the negative things come to the surface. The HIV starts to affect the emotional and psychological side of your life. And because your body is starving for more, and if you have the economics to give it more, then it's more stable. If not, then it becomes a psychological problem. And I don't want to go to a psychiatrist to get a whole bottle full of pills, because pills is not food." The other really strong effect that we see with food insecurity is a behavioral one on medication adherence. So in HIV, this has been well documented. With other conditions, it might be more adherence to self-management regimens, but the idea is is this behavioral pathway. And so in this study, we found that among women living with HIV nationally, that food insecurity, again, there was this gradient. As food insecurity becomes more severe, non-adherence to HIV medications, antiretrovirals, becomes more severe as well. And then this relationship strengthens and becomes bigger as the severity of non-adherence increases. So there's a dose response kind of on 2 dimensions here. And 2 quotes on adherence. "You have to eat when you take ART. If I don't have any food when I take my medication, then I'll get sick and I'll get mad, and I don't want to take the pills." And the second quote: "When I wasn't getting enough to eat, my T cells dropped. Everything. My viral load went up, and I wasn't taking my medication. I literally wasn't taking care of myself. I was dwindling away. You know, I would have both foot in the grave, basically. And all I needed to do is just lay down." I actually wanted to go back to the mental health slide and just mention that in addition to depressive symptoms, we've actually been finding associations in the same population of women living with HIV between food insecurity and generalized anxiety disorder, and also symptoms of post-traumatic stress disorder. And so that's something we're looking into as well. So, if food insecurity is so bad for health, then what is this idea around food as medicine? I mean, this is particularly an idea relevant to people who are living with chronic illnesses, because there are a myriad of ways that food and nutrition are important to health, regardless. But this is really the focus of the talk right now. And so I want to just frame this a little bit. When we think about food as medicine in chronic illness, you can think about sort of a medical need existing, where a doctor has said, you know, you have congestive heart failure, you need to follow this low sodium diet, you need to eat healthfully in this way. I've given you this advice, maybe I've referred you to a dietitian. Go forth and, be healthy. So medical need. On the other hand is the social and economic need. This person who's just received this advice may not have access to that food economically. They may live alone. They may be homebound. Socially, they may not have access to somebody to help them to prepare that, to help them grocery shop. And in that sort of intersecting space is where this idea of medically appropriate food and nutrition support for chronically ill populations has taken place, and formulated under this idea of food as medicine. So what's the evidence for whether or not providing food to folks who have a chronic illness in this way is going to help improve health outcomes? So there's an emerging body of work, still pretty small, about 4 studies at this point. The largest of which was the diabetes box study conducted by my colleague Hilary Seligman that looked at providing a diabetes-appropriate food box, about 1 to 2 weeks worth of food over 6 months. And that was in Texas, California, and Ohio. We conducted a small pilot in San Francisco and Oakland, providing comprehensive support, so 100% of nutritional support over 6 months for people with diabetes and or HIV. There's a heart failure pilot that was conducted in New York and Michigan, and then in Philadelphia. This was medically appropriate meals for a range of chronic conditions. And what we found so far is that there really, if you sort of trace out the ways in which food insecurity negatively impacts health, that when we provide medically appropriate food to populations with chronic illness, we do see some positive impacts or changes, I'll say, in nutrition, in adherence and self-management, and mental health for these top 2 studies that looked at mechanisms. Clinical outcomes, lower A1C, heart failure symptoms, not all of these were quite statistically significant because a weakness of this body of literature still is that studies are still pretty small. But they're all consistently in the same direction, and larger studies are being undertaken to more formally test these impacts. Importantly, there are also changes in healthcare utilization. So decreases in hospitalizations, hospital readmissions, ER visits and inpatient visits and days. So we have a couple studies ongoing to kind of fill the gap and continue to generate some more rigorous evidence with control groups, larger studies. One is Changing Health Through Food Support, which is providing medically appropriate food to people with HIV in the Bay Area, and the other one is Cardiac Recovery Through Dietary Support, which is targeting congestive heart failure for people recently discharged. And those are ongoing with our partners at Project Open Hand and the San Francisco Department of Public Health for CARTS. So what do we do if it looks like this works, right? How do we make this sustainable? So part of this whole food as medicine movement is really about trying to get this approach, if it's effective, integrated into healthcare, integrated as a healthcare funded intervention. Okay. As a healthcare funded intervention, that means paid for by insurance, paid for under a sustainable funding stream that isn't solely reliant on community organizations whose own funding streams and funding bases may be less sustainable, and who are also actually often tied to funding that's coming from these higher levels. So the current policy environment is kind of interesting. How, the Ryan White HIV/AIDS program, I don't know how many people are available or are familiar with what it provides, but it's uniquely the only federally funded source of food assistance for a defined health population. So we have obviously large food security programs in the US. SNAP is the biggest one, food stamps. But this Ryan White HIV program is the only one that actually covers food as a health benefit specifically for people with HIV. So no other sort of person, because of your health condition, could, for example, get meals covered by another similar program. In Medicare, there are some options for limited medically tailored meals, potentially post-discharge from the hospital for certain conditions for a very limited amount of time. Medicaid, there's no inclusion of food kind of across the board. Some states are innovating in their long-term and managed care programs, and Massachusetts, New York, et cetera, and I'll talk about California in a minute. And private insurance is basically off the board as far as we know right now, but there is an effort to try to actually convince them that this could be an important benefit. So in California, back in June, a budget bill was passed that included this food as medicine pilot, $6 million of funding over 3 years to provide medically appropriate food through Medi-Cal for people. I think they're going to focus again on congestive heart failure, but it may be some others as well. This is a first, so this is exciting. It's a program, it's not a study, but it's a pilot program. They are going to conduct evaluation, and it's going to be delivered by local service organizations, a couple of them here in Southern California, so Project Angel Food in Los Angeles, Mama's Kitchen in San Diego. With the Food as Medicine pilot, I think this is extremely exciting. I think this is a demonstration project, and we'll see what comes out of it. But I want to just reflect that this, while it's going to be extremely important for people who are living with chronic illness to address an immediate need that many people have to support their health, we have to continue to think about the upstream determinants. Why is food insecurity happening in the first place? How do we both meet the immediate need and address, way back at the beginning of the talk, thinking about the context in which this is happening with regards to housing and trade-offs and changes in neighborhoods and gentrification. How do we integrate these movements? So I want to go back to that first picture to conclude that I showed, and just make sure that housing is in that picture too. Because food is housing, and housing is health, and together we need to address them in an integrated fashion. And we need to make sure that people who every day are making trade-offs between food and rent and healthcare, that their voices are informing our research, are informing these policies, are informing these programs, and that from the immediate needs to the upstream needs that we're working across the spectrum. I'd like to thank our collaborators, our participants, our funders, and I invite questions, comments. I would be very happy to dialogue with all of you about these issues, as I know there's a lot of knowledge in this room. Thank you.
If people have questions, and we have about a couple minutes, 3 minutes for questions, if you want to ask them now, but we do have a panel later on if you do want to hold on your questions for the entire symposium. But if you have an immediate question, we have a couple minutes. Dr. Guy, tell me to write them down to start. I'll write down the questions on the index.
If you have questions, you could also put them on the card and bring them.
Yes.
I just have a quick question about the diabetes box. Was that the one that was done in conjunction with the food banks?
Mm-hmm.
Yeah.
Yes, that was provided out of the food banks. Correct. Yes.
I mean, thank you for a really amazing, inspiring presentation. I've worked in Mozambique looking at AIDS treatment and some of the exact same quotes. And what people said would tell me in Mozambique is all I eat is ARVs, all I eat is my medication.
Yeah.
And so I guess a couple of questions. The response in Mozambique in clinics and in like policy making, sort of local policy making, administrative discussions was, well, this isn't a health issue. We can't take this on. It's too overwhelming for our already stretched systems. This isn't our problem. So there is this movement to really delimit what is a health issue and what is a social issue. But the way patients, and the community experience this is, and I think there's a symbolism, and I like your early sort of talk about identity and how food is this very powerful symbol. People felt really, really angry that these treatment programs were making them hungry and not addressing it. And so it wasn't just that they were hungry and that was impacting their adherence. People were dropping out of programs and they were actually felt offended, and why would they do this to us, make us hungry and not address it?
Right.
So I guess, and I feel like what you're talking about here is really what we need is a culture shift, right, in medicine. And there's kind of this history, like Jack Geiger prescribing food in Mississippi in the 60s. So I guess I'd be interested in hearing you talk a little bit more about that. How do we, on that sort of big level, how do we move the system to actually, it looks like that's what you're doing, which is incredible.
Well, I think, it's a great question and a great point, and I agree. I think that really the whole food as medicine movement is really the attempt to say, okay, well, how can we carve out a piece that really feels like healthcare, and that insurance companies will recognize as healthcare, that doctors will recognize as healthcare, and kind of get that in first, really meeting needs that are very acute. But I absolutely agree that it can't stop there. And so I think that these kinds of incremental improvements, actually, which are pretty revolutionary for how the healthcare system is organized, are really important. But I think that I think that we do need more solutions, and I don't have them necessarily. I think that continuing to make the conversation happen on this level, I think more and more there is recognition that social determinants is health, belongs in medicine. So having all of the physicians of today really bring that forward into their medical careers. I think having people who do research continue to make those connections. I think the activism and the advocacy and the cultural conversations also make a big difference and need to happen. And those don't all need to happen together, but I think we all need to be connected in those conversations. As far as a specific policy solution, I think that there's so much that needs to change in our society to make our society able to create well-being from that social and economic level up through health, that it's almost, I'm sure we've all experienced overwhelming to even think about where to start, but I think we have to,
I ask everyone else, I'm sorry, to write down your questions and ask them at the panel. For time's sake, we're going to transition and give you guys time to use the restrooms. But give another round of applause for our speaker, Dr. So if you would kindly gather your things, we're going to transition again, but there is time to use the restroom. I can point them out if you would like to.
Yeah. Yes, we didn't, but it's something that in these studies, but we think about and talk about all the time that we need to be, because it's household systems, absolutely. Yeah, absolutely. One interesting thing is that women tend to protect their children from the worst of food insecurity, so they, but at a certain level, even that erodes. So,
in case people didn't hear, the next room will be room 130, and that'll start in a few minutes.
No, yes, exactly. Well, and that's why the food support, I think, has to be at the household level, because it's just gonna, yeah. Hi, Yasmin? Kartika, nice to meet you. Thanks for asking that question.
Yeah, because I was curious, a lot of it is categorized as low income and homelessness, and reaching out to people that have the basics and people that have nothing. So it's like, everything. That's why I was just wondering, the projects and how we target different people. And,
I didn't get to mention that I think a big weakness right now of the food as medicine projects is a lot of them don't include homeless because the actual intervention that's given is like requires you to have certain kinds of storage and cooking facilities. Yeah.
So it's just like
Yeah.
you're starting all over again, learning the different combinations as a community and things like that. So that's just
It sounds like something that we should actually look into more.
Yeah, I think a big investment as far as research should be, focused on that, targeting that particular type of group and the strains on that, and and advancing to even
Would you want me to, the question that you asked about whether those numbers included homeless, did you want me to see if I could find that answer and get it to you? It would have to be later, but I don't know if you have an email or something.
I do, and also when you have a card.
Yes, I would be happy to. Hi, just a minute.
Thank you so much.
Thank you.
Just to know, I definitely do or know anybody that's working on information gathering in Orange County.
Oh, I might. I can find out. Yeah. Thank you. What was your name? Archie. Nice to meet you. Sorry. Excuse me. Here. Hi. Hi.
I would love to follow up with you.
That'd be wonderful.
Yeah. I went to UCLA. I got an PhD in
Oh,
anthropology.
wonderful. Oh, cool.
And
Who did
I know Sherry
you work with? Oh, you know Sherry?
From way back, yeah, from medical school. She was an attending when I was a
Yeah.
student.
Yeah.
Already, but I love her work. I cite her work all the time.
Politics
or IPI.
Apologist. IPI.
Yeah.
Nice. So what you're, oh, congratulations.
I'm trying to turn my moving work into but it's all about these treatment programs
Yeah.
ended up actually providing this amazing care, but they ended up having also creating all this exclusion, this weird way of sort of providing some hospital on others. Anyways, but I'm a psychiatrist now.
Oh.
I've got residency.
It's like you have a lot of hats, it sounds like.
Too many.
It's kind of awesome.
Kind of, but it's sort of like it keeps me from. It's counterproductive a little bit, but.
Thanks, Yasmin, and thanks for your perspectives. I appreciate the questions. Thank you.
I just want to finish my book, finish the most unique stuff, and I'm super interested.
Yeah.
But coming back to food insecurity and
Okay.
mental illness, and kind of tying it to like social determinants and all these factors,
Yeah.
housing. It's so inspiring to see this and see where, because
So
I sort of have, I've followed Sherry's work, but this is all new to me, like the more recent stuff.
Yeah,
and your
yeah,
work's new to me, but it's super exciting.
Well,
So
she's
we'd
my
love-
she's my primary mentor. I tell.
Yeah, so I'd love to follow up. And
Yeah, you should
talk about, and
jump back in.
And you have a you have a background here, so that you know local
Yeah,
people
yeah.
I could connect with, and I would just love to sort of dialogue with
Awesome.
you guys.
Okay, well, please be in touch. Let me get you my
Yeah,
card
yeah.
as well. I know, I wasn't. He was like waving at me. I was like, what? Oh. There you go. Nice to meet you. Oh, okay, good. I need to.
We pushed the whole schedule back to 2:30.
Oh, wait.
All right, so
Just give me 1 minute.
we'll be starting exactly at 10, so you have 2 more minutes. All of the next transitions will be much smoother, I promise. Thank you, Jeremy. Just in case anyone needs to go to the bathroom, I realized I didn't make this announcement in the last session. You can either go straight down and you'll see the bathroom placard sign thing, or you can make your first left and you'll see another sign. So there's 2 different bathrooms you can go to. All right. Okay, but we'll go ahead and start now. And I just wanted to introduce Dr. Kartika Pawar. She's an assistant professor in the Division of HIV, Infectious Disease, and Global Medicine at the UCSF School of, at the University of California, San Francisco. And her interdisciplinary research focuses on the social determinants of health in HIV, diabetes, and other chronic diseases. So today she'll be talking about food insecurity and its effects on health. Thank you.
Thank you. All right, can everyone hear me? Great. I'm not used to these portable microphones. Wonderful. So I'm really happy to be here to be able to talk about food insecurity, and particularly food insecurity in the context of gentrification. And while I'm going to be talking mostly about food insecurity and health, I'm going to always try to keep tying it back to ideas around gentrification and particularly housing insecurity. So by the end of this talk, I'm hoping that you're going to understand 3 things. What is food insecurity? Who does it affect, and what does gentrification have to do with it? How does food insecurity undermine health? And there's an approach now to try to integrate the role of food in healthcare that's people are calling food as medicine. So I want you to understand a little bit about that and its promise, and maybe some ways that it can move forward addressing other determinants. So food insecurity 101. I want you all to take a moment and think about the last meal that you had. Maybe not the one here, wherever, yesterday. Let's pick a meal from yesterday. Think about what you ate. Just get that in your mind. And now think about where you got that food. Where did it come from? Did you buy it? Did you cook it? If you cooked it, where did you buy the groceries from? How much did it cost? Was anything about it stressful to you? Or how did it feel to eat that meal? Was it soothing? Was it relaxing? Who were you with? What did the food remind you of? Maybe that was something that you used to eat when you were a child, etc. So think about all of that. And the conditions in your life that kind of brought you to that one meal that you probably ate and didn't necessarily think, 2 thoughts about. And I'm asking you to do this because when we talk about food, we are talking about something that's physiological necessity. It's a fundamental biological, chemical part of our existence. If we have too much of it, too little of it, it can cause disease or even death. But we need it. But food is also emotional. It's mental, highly emotional and mental. Food can be love. Food can be stress, can be pain, can be shame, can be joy. Food is often at the centerpiece of our relationships with our partners, our friends, and our families. Food happens in a context of community often. It's related to our identity. What we eat is absolutely governed by our behaviors and things that we choose, but it's also affected by what we can afford, where we live. And systems, local all the way through the global, that are affected by economics, ecology, and there are disparities in those conditions that affect food and affect health. So thinking about really all of those things that food is, let's think about food insecurity. So when we talk about food insecurity, we're talking about limited ability to procure adequate, healthy food for a healthy lifestyle. But we're also talking about uncertainty in being able to procure that food. So it may not be limited today, but if you don't know where your next meal is coming from, that's also food insecurity. If you can procure food, but the only way you can do it is in a way that's personally or socially unacceptable in the world that you live in, if you have to resort to stealing at some point, for example. You have the food, but that's also food insecurity. So here's how we actually think about measuring food insecurity or describing the experience. It's not just a binary thing. There's categories. It's a spectrum, but we generally break it down into these categories. At the very bottom is the most severe level of food insecurity, very low food security. This is where we see disrupted eating patterns, reduced food intake. This is where we would see hunger. But food insecurity isn't just hunger, although those are often used synonymously. Food insecurity is also a reduction in access to quality food, a variety of food needed for health, the cultural desirability and acceptability of the diet, even if food intake itself isn't reduced. Going up the chain, marginal food security, which is included in some definitions of food insecurity and not others. I tend to include it in my work and in our work on health. We tend to include it, is when there's a lot of anxiety and worry about where food is coming from, even if the food is actually there, but if you're spending a lot of time worrying about it, due to not knowing if there's resources to obtain it. So we know that food insecurity measured by those bottom two triangles affects about 41 million people in the US. This was from 2016, USDA survey they do every year, representing about 15 million households. All right, audience participation moment here. I have two quiz questions for you guys. Think about all of the food insecure households in the US kind of along the ways that I was defining it. And think about the poverty line, which is about $25,000 for a family of 4. Raise your hand if you think that almost all food insecure households in the US are under about half of the poverty line. One hand, one brave hand. How about at the poverty line? How many people would say? How about 1.5 the poverty line? I see a few more hands. This is a shyer group than this. How about 2 times the poverty? All right, a bunch of hands. 2.5 times? Bunch more hands. All right, so you guys actually, you did pretty well. I'd say the last group was evenly distributed pretty much among all of the answers. It's about 2 times the poverty line. And that's often a threshold that's used to kind of when people talk about low income in a general way, that when it's quantified, it's often quantified at around that point. The point is simply being, as you probably already know and intuit or just understand from what we've been talking about, food insecurity is closely tied to income, and because it's about resource constraints. But now I'm going to flip it a little bit, ask a different question. What percentage of households under the poverty line do you think are food insecure, using the definition that we discussed? the bottom two triangles. Who thinks it's 30%? How about 40%? 50%? I see a hand. 75%. A few more. 90%. So the answer is actually 38%. I put 40% because I thought if I put 38, that would be a giveaway. So I think why people are surprised is because I think, food insecurity and poverty do seem so tightly linked. But the truth is, and they are, but food insecurity actually is affected by many other things than income. It's affected by the resources we have in our environment, access to safety nets, social support, affected by our geography. It's affected by potentially the strategies we're using to manage whatever income and resources we do have that varies across households and across people. So at any given moment, only 40% of households under the poverty line are food insecure. There are frank and persistent disparities in food insecurity along race and ethnicity. Latino and Black households consistently have disproportionately high food insecurity compared to white households and compared to total US households. So now I'm going to talk a little bit about food insecurity in the context of gentrification. And I'm just going to preface this by saying there are, I am sure, many ways that food insecurity is tied to gentrification. Gentrification is not my field, but thinking about this in the context of what I do know about food insecurity, there's really two main ways that we see gentrification may be affecting food insecurity. So one, and the one I'm going to spend the most time talking about, is housing insecurity, and particularly the cost of housing and displacement. The second one is changes to the neighborhood food environment. This is really important. I'm not going to talk that much about this because there's a huge, very robust literature on this, a lot of debate. It's very interesting, and I encourage you to, if you're interested, read up on it. One thing I will say about the neighborhood food environment is that it doesn't seem so simple as putting a grocery store in a neighborhood that hasn't had one. It could be. There's some evidence that it could improve food security, diet, and health outcomes. Other studies don't show that. It may be more nuanced. We need to look closer at what kind of stores they are. What are the price points? How are they marketing this food? Are they culturally acceptable? Do people actually want to go into this store? Does it reflect the kind of food that they eat and want to eat? But let's talk about housing insecurity for now. And there's two aspects I'm going to talk about. The first one is food budgets and the trade-off that people make between cost of housing, cost of food. Really basic. I think we all experience it in one way or another when we're doing our monthly budget. But for people who are on very low incomes, this trade-off is often non-negotiable. There aren't other sources of discretionary income to come in and fill the gap as rents go up. If you're in a neighborhood that's gentrifying and your rent starts to go up, you have a choice to pay it and then reduce on the other side somehow. Or you have to leave and deal with the cost of that and how that affects your food. We do know that people who rent are at higher risk for food insecurity than homeowners, given the same level of income. And there's very interesting work that's come out recently looking at cost of living on the county level and what happens to consumption of healthy food. And so a recent study showed that, that was national, showed that living in a high cost of living county, specifically determined by or measured by rental costs, so that was the metric for cost of living, was associated with poorer kind of nutritional status and dietary quality across the board, and lower scores on the healthy eating index. And what was interesting was that the cost of living index that they used that was pegged to rent was more predictive of these issues around food insecurity and diet than actually the cost of food, the metric based on the cost of food around cost of living. And so I think that just shows that the place of housing and rent and that cost is really so powerful in affecting food security and the ability to meet basic needs generally. The other piece that I want to talk about is what happens when people are either displaced to poorer quality housing or already live in poorer quality housing and can't afford to move out, or at the most extreme level are displaced and become homeless. Food insecurity is also not just about the cost of food. It's also about whether you can utilize the food that you have. So if you have access to food, but you don't have a safe and sanitary or even a physical place to store and cook the food and eat the food, then you're going to still struggle with food insecurity. And actually, the point that the speaker this morning brought up around water, I think is another really important point that is increasingly recognized as part of food security. Water security and food security are very tied for this reason. So in 2014, we did a study to explore the experiences of people living with HIV in the San Francisco Bay Area, so mostly in San Francisco and Oakland, on health, and understand food security and health in this population. And it was amazing that when we asked people about their experiences of food insecurity, really powerful themes around gentrification, rent, housing came up immediately. And so we published a paper on that. And so here are some of the words from our participants describing their experiences of this. The first one said, "The Tenderloin is changing a lot. The rich are trying to get in here and live here. They want to kick all the sick and poor out, and they're being successful at it too." The second participant said, "You've got to pay rent or be in the streets. You've got no choice to make. And the SSI, which is Supplemental Security Income, disability income for people who are not aware, don't go up. I mean, you may get $1 or $2 or maybe $5 every 2 years. But rent goes up, once a year? So what can you do?" This imbalance between disability payments and rent in the context of a very high cost of living area, I'm sure you would hear very similar stories here in Los Angeles. So then what comes next? A trade-off between rent and food. Recently, most of the people who are actually housed in this study were so because they had rent subsidies. That was the only way that they were able to even stay in the Bay Area on disability income. And one of them said, "Recently, I just got the $200 rent subsidy within the last 6 months. I only get $925 a month. And before then, I was paying the whole $900 for rent, and I was getting food from the food bank and Project Open Hand and just where I could, because I couldn't afford it. But I had to have a place to stay." Between a rock and a hard place. So I'm going to move on now to talk about the evidence that we have around food insecurity and health. Starting with this diagram that shows a cycle of food insecurity and disease that was published by my colleagues at UCSF, Hilary Seligman and Dean Schillinger. And I apologize, it might be a little bit hard to read, but I'll just kind of mention the important pieces, which is that food insecurity at the top can lead to constrained dietary options, as we've just described. And in that context, people take strategies, compensatory strategies, that may vary during food shortage and food adequacy. But for example, when money is tight, buying food that's cheaper, has higher caloric content. But even when maybe money is plentiful again, sometimes those strategies stick and people continue to eat in ways that were formed during periods of food insecurity. And together, that can lead to weight gain, hyper and hypoglycemia, and ultimately to hypertension and diabetes. Once people are living with these chronic conditions, it becomes difficult to, in the context of food insecurity, to manage them because you need to follow a special kind of diet. You have to be aware of what you're eating. There's competing demands between medication and spending money on your medications and on your transport to go to the doctor and do all of that, and food. Stress is a very important accelerator of this whole process. People can continue to gain weight or just have their diabetes, for example, not be in control, can lead to disability. Diabetes is the leading cause of amputations. So that can all lead back to food insecurity, and it just continues on in a cycle. This is a real 30,000-foot view of the research in terms of what we know about how food insecurity is associated with poor health outcomes. And you can just see this cascade of conditions. This is just what's been studied, what we have data to look at. And I think there's even more than this that's been recently published on that didn't make it into the slide. Food insecurity increases the risk or is associated with prevalence of all of these conditions. But really the focus of most of the research has been on diabetes and HIV. And in those, we actually have a chance to see across the range of health experiences, when people are living with a chronic condition, it affects adherence and self-management. Food insecurity has a profound impact on mental health. We'll get to that a little bit later. Is highly associated with poor clinical outcomes. So for HIV, increased viral load, reduced CD4 cell counts. For diabetes, it's associated with worse control of diabetes, higher A1C, higher blood sugar, more hypoglycemic events, et cetera. Both also associated with increased healthcare utilization and acute care use, hospitalizations, and ED visits. So some of the pathways that lead from food insecurity to some of these poor health outcomes have been traced out by Sherry Weiser at UCSF. And I'm going to take a moment to just walk through each of these pathways with regards to some recent findings that we've had through some of our studies, just to illustrate, I think, what some of this looks like, what some of the data looks like. Importantly, I'm going to follow each one of the kind of number slides up with a qualitative quote to help get underneath the numbers and give a sense of what this actually feels like from a lived experience. So quickly, food insecurity is associated with poor nutritional outcomes, poor diet quality, both overweight and obesity and underweight, and difficulty meeting health-specific dietary recommendations. And one of our participants in a recent study who was living with diabetes said, either you go hungry because you don't have the money for fruits and vegetables, or you're eating empty carbohydrates, say like pasta, spaghetti, mac and cheese, you name it. That will last you 3 or 4 days. So here you're eating this stuff that isn't good for you. It turns to sugar, but you're kind of stuck between a rock and a hard spot. So moving on to the mental health pathway, there's a lot of evidence that food insecurity is linked to depression and depressive symptoms, really in this gradient that's very clear across a couple different populations. So women living with HIV nationally in the US on the left, and homeless and marginally housed folks living in San Francisco and living with HIV. Very similar kinds of results. And this is what they had to say about it. When you don't eat properly, then all of the negative things come to the surface. The HIV starts to affect the emotional and psychological side of your life because your body is starving for more. And if you have the economics to give it more, then it's more stable. If not, then it becomes a psychological problem. And I don't want to go to the psychiatrist to get a whole bottle full of pills, because pills is not food. When we think about medication adherence, we also see this very clear gradient of food insecurity and non-adherence. And what's interesting is if you break it up by levels of non-adherence, you also see a gradient kind of across levels of non-adherence. So there's really kind of two levels of dose response, it looks like, that's going on between the relationship with food insecurity and adherence. And what we really see is that for people who are severely food insecure and severely non-adherent, this is a population that I think we really need to pay attention to. We're not reaching with our interventions. Oh well. Okay, moving on. Words about this. You have to eat when you take ART. If I don't have any food when I take my medication, then I'll get sick and I'll get mad, then I don't want to take the pills. And when I wasn't getting enough to eat, my T cells dropped, everything. My viral load went up and I wasn't taking my medication. I literally wasn't taking care of myself. I was dwindling away. You know, I would have won both foot in the grave, basically. All I needed to do is just lay on down. So I have about 5 minutes to talk about food as medicine, so I'll try to go through this rather quickly. And this is the flip side, okay? If food insecurity is so terrible for health, what kinds of things can we be doing to address this? So food as medicine is one approach that's trying to take the intersection of medical need and social and economic need and kind of address for people with chronic illness, how can we help support health in the context of food insecurity? There's a lot of things that are on the outside of the intersection that are very important, that are not the things that we're talking about today, including things like our big food security interventions like SNAP, et cetera. So what we're really talking about are targeted interventions to really deliver medically appropriate food to chronically ill populations who are food insecure. And there's 4 studies at this point that have published or disseminated some results. And I'm not going to go into their details, but if anyone's interested, you can ask me later. We do see some very interesting results that are pretty consistent across the studies that looks like it is improving the things that are on the pathways towards health or towards sort of the HIV or diabetes health, for example, the nutritional pathway, the mental health, the adherence. The actual clinical outcomes, we also see some promising results. Not all of these are statistically significant at our normal levels of alpha of 0.05. Some are closer to 0.1, but they're small studies, so I think it's promising, and we're following them up with larger studies. Also promising results on healthcare utilization and reducing healthcare costs. We have some ongoing studies. I won't talk about those now. I did want to mention that the whole point of this research is to generate scientific evidence. What happens with that evidence? There is a movement, the food as medicine movement, that is seeking to specifically integrate these kinds of interventions as healthcare funded interventions. So things that can be paid for by insurance, a doctor can prescribe food, things that will be covered by insurance as part of the approach to treating a chronically ill person, for example, with diabetes. Right now, nothing like that really exists, not much at least. The Ryan White HIV/AIDS program is the only federally funded source of food assistance for a defined health population. It's not a diet-sensitive condition per se, but because of the history of the HIV community really advocating for comprehensive care that included wraparound services, that's now included in Ryan White. But a lot of other people need that kind of support too, and it's not quite there yet. Medicare, there's some limited options, nothing in Medicaid, although states on their own are innovating in this area to some extent in pretty exciting ways. And so I wanted to talk about just I have just 2 more slides. a really exciting pilot is starting that was funded and signed into law last June to conduct a pilot of integrating medically tailored meals into Medi-Cal for people with congestive heart failures, and then delivered by local service organizations, $6 billion over 3 years. And that's just starting, I think, this month. So if anybody is working with these organizations or familiar with them or maybe has heard about this, keep your eye on this, because I think it's going to be really interesting to see what comes out. But thinking back to some of the stuff we started the talk with, this is very exciting, and I personally am very excited to see how this may improve health and change the landscape for food as medicine. But it's important for me to also remember that this is an intervention to help people who need acute assistance now. It's not going to address the sort of upstream social determinants, and it's not meant to. But we need to continue to think about what else this could complement. What else could we be doing to make food as medicine be a little broader? Food is health. Food is justice. Food is much broader than medicine. And so to conclude with this slide that I started with, I did put housing into this picture because I do believe that food is housing and housing is health, and together they are health. And we need to be working together really on all these fronts, those of us who work on food or on housing or on gentrification or on research, community, activism. So all of us need to come together, I think, to be having these conversations and prioritizing and including the voices of people with the lived experiences, trying to balance food and rent and healthcare every day. I think that's absolutely essential. And we'll continue to do that in our research. I hope all of you continue to do that in your medical careers and research and community and your lives. Thank you so much for having me. I want to thank my collaborators, participants. Any questions or no time?
So we ended exactly on time, so I'll be taking you to the next room, and we will be having a panel after the next session. So if you do, after the keynote, I'm sorry. So if you do have questions for Dr. Pilar, you can save it for then, and we'll be having the panel for at least an hour. So thank you. And then, okay, I can lead you to the next room.